Next, I'm proud to have another alumni come back, Tim Bradford, to talk about something that he's been building quietly over the years, and it's amazing what he's done. It's his adventures in helping the world. Welcome back, Tim. Thank you for coming all the way back to Michigan.
Hi, everyone. Thanks for having me. I'm a Nesbit 2008 member, and as a Duke grad, I can also echo Dr. Farber's sentiment. Cameron and Big House are two of the best. You should definitely get there if you haven't been there before. I'm here to talk to you today about Global Surgical Expedition. No disclosures. I'm going to start out with a story about Kim. For as long as Kim could remember, she had been incontinent. As she grew older, she continued to be incontinent. She did not have access to diapers or pads. She was constantly wet, constantly smelled of urine. She was absolutely shunned by her community. She could not interact or date. She couldn't hold down a job. Her family was basically her only support, and she confided in us that she was contemplating suicide. Surgeons from Global Surgical Expedition evaluated Kim in 2014, and we discovered that she had an ectopic ureter implanting into her vagina, which was a relatively easy fix with a ureteral reimplantation. She recovered great and was dry thereafter, and it changed her life. So the problem is surgical disease. It's estimated that 30 to 50% of the world's population do not have access to surgical care, which means that millions and millions and millions of men and women and children are suffering from disability, death, and poverty from surgical disease, which could be avoided. It's estimated that 143 million additional surgeries are needed annually to meet that need. So what does lack of surgical care mean? Well, take a ureteral stone in the States, that's a ureteroscopy or a shockwave lithotripsy, easy 30-minute procedure. In a low-income country, that means they do not have access to that surgery. That means waiting for that stone to pass, pain, not being able to work, and ultimately, potentially, kidney failure and death. Similarly, with a leg fracture, pretty simple procedure in the US, but in a low-income country, waiting for that to heal on its own and potentially ending up with lifelong disability. And then you have to think about the overlooked impacts of surgical disease, not just on the patient, but on families and generations. What we know is that, for example, a patient like Maria who has incontinence, she has leakage, she's embarrassed, she has pain and discomfort. But ultimately, she may require frequent visits to the doctor. She needs pads that she can't afford. And what you overlook maybe is that when she travels to the doctor, her husband may have to take off work to look at the kids, and that they're losing income, which is desperately needed. Similarly, a gentleman with BPH, we understand the frequency and urgency that's a bother to him, but once he gets a catheter for retention, then he's traveling to have that catheter changed every 2 to 4 weeks. He's missing work. And what that leads to is a generational impact where maybe those people can't provide the money to send their kids to school, maybe they can't feed their kids, and maybe their kids end up in this same cycle of poverty for generations to come. So if 30% of disease is surgical, who's helping? Well, there's a lot of big medical charities out there, Partners in Health, Doctors Without Borders, Gates Foundation. But when you look at surgical disease, who's really helping with surgical disease? There are organizations out there, certainly, but there are a few large organizations. Everybody's heard of Operation Smile, Smile Train, that's very focused on a small population. Pediatric Surgery, World Pediatric Project is actually based out of Richmond, and we've done a lot of work with them. But when you look at the subspecialties, there's not a lot in terms of large organizations really helping. You say, well, urology, what about International Volunteers? Your IVU does great work. But comparatively, they're a small organization. They are less than 1% of the annual revenue of something like Operation Smile. So they're a relatively small organization. And there's a huge opportunity. So my first mission trip experience was in 2006 when I accompanied 3 other urologists from University of Michigan to Haiti. We did a lot of TURPs. We did orchiectomies for prostate cancer. I remember specifically that we did a ureterosigmoidostomy for a child with exstrophy. Here's your team. You may recognize Dr. Park, Dr. Wolf, Dr. Montgomery, and myself. That picture on your right is Dr. Montgomery and myself after we did a surgery in a Haitian OR with no air conditioning. Perhaps the only time I've ever been sweatier than Dr. Montgomery. But it was rough. I joined Virginia Urology in 2009, and I met a senior partner there named Dr. Kinlaw Nelson. He had been going to Belize for years doing minor procedures, piggybacking on World Pediatric Project, which is based in Richmond. My good friend, Dr. Dave Rapp, and I decided to go to Belize City in 2010, and we saw a huge need. And we continued to do annual trips over the next several years with the goal of kind of formalizing and expanding the operation. And much of this credit goes to Dave Rapp, my partner. But in 2012, we founded a 501c3 charitable organization called Global Surgical Expedition with the intent to improve access to surgical care worldwide. We selected Belize as the initial site due to pre-existing relationship. Our initial efforts were focused on equipment and learning the logistics of foreign health systems, getting comfortable operating without blood products, without ICUs, things. Just making adjustments. And then we built relationships with local administrations and surgeons, and then we just started recruiting surgeons, anesthesiologists, CRNAs, all the people that you need to build teams. We added a resident scholar program along the way. We hired a local liaison in Belize, and then through the years we've added additional sites in Africa and Central America, and we've also added gynecology and general surgery. So this is not intended to just be a urology thing. We're trying to make this a full surgical expedition. So just a snapshot of the GSE history, where we started in terms of Belize, and then Ghana, Rwanda, Botswana, adding the subspecialties or the other specialties, adding the research program. And we've also become a member of the G4 Alliance, which is one of the largest, if not the largest, advocacy groups trying to promote global surgical health. They work with World Health Organization and multiple national governments around the world. A little video here about some of the beginnings of GSE.
When we first began, there wasn't a lot of infrastructure. So basically, we would get on a plane and go down to a hospital in the capital city of Belize that we had formed a relationship with. So it was very, very basic at that point, and it was just Tim and I at that point.
The first trip was difficult. It was logistics were very difficult, and just getting from place to place and making sure that we had the equipment that we needed to have.
What was more notable was, yes, there were complicated surgeries that needed to be done, but there were also very basic surgeries that weren't being done, that in the US will be done as an outpatient in 5 minutes, but down in Belize can cause lifelong disability or even death, and that was really shocking to me.
I always had pain all the time, many accidents, and it was horrible for me.
He had a mass on his right kidney.
I was peeing myself constantly, that I had to walk around with a big purse with pads on, and every minute I had to change my pads because the urine was just coming down a lot.
I had a kidney tumor.
Many of these women that we take care of have been completely abandoned by family, friends, and really their entire communities. And I've been really impressed by their ability to handle this situation with grace and dignity, and how they can maintain a sense of hope.
All right, I'm going to go back with the next case, but it was real nice meeting you and working with you. You're welcome.
Thanks, Doc.
You bet.
Thank you so much.
You bet.
Thank you.
Doctors come here to help the sick people. That's a big help for us, because, for example, a surgery, some surgery costs $8,000, $10,000 in a private clinic, and sometimes you can't afford to pay that.
I would really like to see this charity grow. I think we can accomplish tremendous things if we had more resources.
You can just change somebody's life overnight. You can have them take them out of social isolation and put them back in society.
gusa Imana izakomeze ibahe ubushobozi bakomeze bavure n'abandi.
I know my kidneys were bad, were packed up with stones and stuff, but for some reason, like, it didn't bother me to say that, man, you could be dead in like a year or two or something like that. I never thought about it like that. I always had that optimistic mind that something is going to happen, because, man, I don't know, that's just me, man.
The Lord answered our prayer, and today is we feel very happy today because she already went for a surgery this morning, and everything is coming okay, and now we are very, very happy with those doctors are coming through to Belize and try to help the poor people like us.
It's amazing what they did for me, for my life. Then this is me now.
Now I feel really good, like if nothing happened. For real, I don't have no pain.
They did the surgery, and now I'm free. I don't have to walk around with a big purse, and I don't even have to wear panty liners. So I'm doing great.
Everything changed.
Yo, good.
Wow.
So this is just a representation of kind of where GSE is now, and we've got multiple sites in development as well. Haiti, Jamaica, India, and a lot of other countries have reached out as well. So U of M alumni have been involved with GSE since 2016 when I took Dr. Hafez and Dr. Schuster down to Belize with us. And a couple of the nurses from U of M as well that a lot of you may know. Here's Dr. Hafez and Dr. Schuster representing the Maize and Blue down in Belize. And since that time, Dr. Schuster's been leading a team every year, and Dr. Taub has also been helping out with that. And this is a picture of another Nesbit surgeon, Dr. Randy Vince, with me. I think I'm observing him do a terrible job on a terp or something like that when he was down there. I called him bare hands because he was so just so aggressive sometimes, but I'm like, dude, we don't have blood here, you gotta slow down, you know. So he gave me some palpitations a couple times. So the most common surgeries that we do down there were TERPs, a lot of prolapse repair, and a lot of incontinence. Dave Rapp, my partner, is a urogynecologist, so I kind of handle the one side and he handles the other side. Then we brought in a lot of other folks as well, but urethroplasty is quite common. For both stones and cancers, cystolithotomies for bladder stones like the one pictured there. Some less common surgeries in the States, but more common there, ureterolithotomies, pyelolithotomies. These were both from our last trip in June. They don't have endoscopic stone treatment there, so we're doing a lot of ureterolithotomies and things like that. Just a snapshot of where we're at this point, 1,500 plus patients treated with over 38 surgical teams deployed. We've had 16 resident scholarships gone with us, about 600 surgeries performed, but tip of the iceberg. So another story, Delvin was a 12-year-old boy when we met him. He fell at a park on a balance beam. He woke up unable to urinate, urethral injury. He got a SP tube by local doctors. He had that SP tube for 2 years. When we met him, there are no surgeons in Belize that can perform urethroplasty. 2019, my buddy Dr. Grossgold there, who's a Navy surgeon, a urologist, did his urethroplasty, got him tube-free, and he's back to a normal childhood. So what GSE is really looking to do is help fill the need, but with an innovative approach. What we really base our approach on is four pillars of advocacy, education, surgery, and research. And we feel like those four pillars lead to more patient impact and better outcomes. This is a busy slide, but just to give you an idea, just sending surgical teams down there is great, but it's not enough. So education to develop surgeons in country, but also to develop curricula for surgeons in the U.S. to become humanitarians in their careers, advocacy to raise awareness and raise money. Surgery not only means providing surgery and surgical equipment, but also developing collaborative services and hopefully allowing foreign health systems to be able to deliver more surgeries after we leave. And then I think a really important part is the research. looking at what diseases cause the most disability and death, what surgeries can have the biggest impact on poverty and are most cost effective. This is another way of looking at it. With just surgery alone, we can kind of increase our surgeries over the year, but when you add in the education, then we've also trained foreign surgeons, we've trained residents, and then when you add in the research, we've decreased the cost per surgery, and we've figured out which surgeries are actually the most beneficial by able to return income to these people. Another busy slide, but looking at kind of each of the pillars and what we have been able to accomplish with each of those pillars. Some of the research that we've done, this was a publication showing that the mean income loss related to urologic disease in working patients was 55% of their total income. I mean, and that's huge for people who are making, you know, tens of dollars a week. I mean, this is huge. The highest income loss was in BPH and oncology patients, mostly related to just catheter changes and stuff like that. So we were basically able to show that by focusing on these surgeries, we could really help combat poverty. Another project that we did was initiate pelvic floor physical therapy. This was a pilot study in Belize where we had some physical therapists go down with us, and they were able to teach 28 women and had follow-up over the course of a year or so, and it turned out they had really good comprehension and good improvement. And so here's another way that we can impact without surgery, but hopefully get people back to work and back to a normal lifestyle. The education part is really important to us to improve care. We want to foster the next generation of global surgery leaders. So we do bring residents with us, but we also have developed through UVA and VCU a formal global surgery curriculum and a certificate program, which Dave Rapp deserves credit for the majority of this, is heading up and does a great job with. And here's just a video on resident education.
When I was a senior resident. So I went on a trip back in September of 2021.
The trip that I went on was to Belize, and that was in 2016.
My trip was actually the first trip after the pandemic hit.
For GSC trip, we went to Belize City.
So GSC really has 4 pillars to its programming, one of which is the educational. And the goal overall for the educational pillar is to create and really foster the next generation of global surgery and humanitarian leaders. And that's a large task. Global surgery is really expansive. It's certainly part medicine and science. The science of surgery is something that students and residents learn throughout many years of medical school and residency training, to be sure, but now they have to learn to do it in a different way without the resources that they've been accustomed to.
I think many of us are especially in reconstructive surgery, are perfectionists in general. But when you're in a place that you can't give blood transfusions, there's no ICU.
So really what you have to do is, in a way, deconstruct what they've learned and teach them to do it in a different way. But it's also much more diverse than that. It's part history, teaching them about colonialism and the health disparities throughout the world and why we are where we're at. It's part leadership, teaching them how to inspire and engage a team of volunteers and also collaborate with local healthcare providers and administrators to deliver that care.
About half of our trip that I went on back in 2021 was centered around meeting with various health officials. You know, before I did that, I had a pretty superficial understanding of what it meant to provide global surgery.
It's part research. The research that we do is trying to understand how we deliver care in these settings with more impact and more sustainability.
And I had detailed conversations with the family members about the personal and the financial impacts of the patient's medical conditions. We were able to present that at a national meeting and also soon to be published to really educate the world on the type of dramatic impact that urological conditions can have on people's financial well-being.
So we start with exposure for young learners through our GSC student and resident scholarships to participate in these trips.
What I saw over the course of a week in Belize was far more varied and far more advanced than what we see at a typical tertiary care center. which is, to put that in context, somewhere where patients in the United States get sent when they have advanced conditions that need a higher level of care.
I appreciated when we were down there that Dr. Rapp and Dr. Bradford, the, I guess, level of respect that they gave me.
But that's the tip of the iceberg. And is where I really think that GSE is doing something unique and different. We really want to supplement that experience with longitudinal formal training for these learners. And for our most committed learners, it takes place in the Global Health Leadership Track.
Both my participation in GSE and the Global Health Leadership Track has been really helpful in allowing me to understand those things.
The point at which I went on this trip, I was at the end of my, towards the end of my training, and I was able to see how I can fit this into my future practice. And actually, now that I'm junior faculty at University of Virginia, I plan to continue going on trips and then continuing to pay it forward and train the future generations, just like I benefited from the mentorship through GSE.
That experience affected me in so many ways. First of all, it came at a time in my training where I was really suffering from a lot of symptoms of burnout. There's a lot of pressures, there's a lot of continuous stress from being within the medical training system, but it allowed me to really just center and focus on what drew me to medicine in the first place.
Surgery, medicine is very tough nowadays, and it's oftentimes easy to question whether it's worth it. It's easy to forget that being a surgeon and a physician is really a privilege. It is a privilege to be able to go and do what we do and care for people and have that intimate relationship in these settings where people oftentimes have no access. It is so visible. That is also a lesson that I hope to instill on the residents and students that I work with, and it very much helps with burnout and helps see our careers in a much different light.
So I know I'm over time here, but real quick, one more story. Shafan was a guy that we met who was wheelchair bound due to a spinal cord injury from a gunshot wound. He was a stone former. The only way they could manage his stones in Belize was just with stents. And when we saw him, I don't know if you can see there, a portion of his right stent had broken off in the right renal pelvis, and then the left stent was embedded in a staghorn, and we couldn't get it out. His renal function was deteriorating. He was bound for dialysis or bound for renal failure, and dialysis is not really available there. So that basically means death. We brought him to Richmond in 2018, and we got his stents out and his stones out through some antegrade and retrograde procedures. So this is my 3-slide pitch. Our vision is to, continue to expand not just urology, but all surgical care throughout the world. Like I said, this is a snapshot. It's a tip of the iceberg, but there's so much more to be done. We've been successful through funding, mostly from fundraisers and family and friends and stuff like that, but we need sustainable funding as any organization does. And that's where we're at, where we would love to grow, we would love to continue, and we're looking for ways to do that. If you're interested in joining us and helping in any way, please contact me, let me know, get on board. Here's a QR code if you want to go to the site, but we'd love to have you. Thanks.